Hello and welcome to this special show on Rajya Sabha Television. I am Vishal Dahiya, and today we are going to talk about the concept of herd immunity. How feasible is utilization of this particular concept to fight COVID-19? In fact, there is a statement which has come in from World Health Organization wherein they have strongly refuted the idea of using herd immunity in the battle against COVID-19 pandemic, with the Director General of WHO clearly saying that it is both scientifically and ethically problematic. So we'll look at all the aspects of this concept of herd immunity. We'll try and understand it much better in terms of Indian context as well. And for more on this, we're joined by a distinguished panel of guests. Let me first introduce them to you, beginning with Dr. S.K. Singh, Director, NCDC. He is also a member of the National Task Force on COVID-19. We also have with us Dr. Samiran, Panda, Scientist G and Head of the ECD Division in ICMR, New Delhi. And we also have Dr. Rajib Dasgupta, Chairperson of the Center of Social Medicine and Community Health at Jawaharlal Nehru University. Welcome, all of you gentlemen, to Rajya Sabha Television. Let me begin with you, Dr. S.K. Singh, and let's start by, making our viewers understand what exactly is herd immunity.
I think if I put it in a simple words, it basically means that a large proportion of population, either through vaccination or through disease infection, gets a sort of immunity against the particular disease. Then we say that the mass spread of disease is prevented. So that is how a herd means a particular group of people gets a protection from the disease. It is either it can be achieved through vaccination or it can be achieved through mass spread of the disease. But both ways, it is basically to contain the spread of disease.
Okay. And how effectively, or whether it has been used previously in any public health outbreak or a pandemic situation as well? Do we have any evidence-based strategy or study of herd immunity being used in situations like the one which we are facing right now?
You see, this particular situation is unprecedented. We haven't had pandemic of this magnitude ever before. So what I can really compare with the herd immunity of other diseases like poliomyelitis, like measles. There have been many instances where herd immunity has provided, because in these diseases, when we take the immunization to the level of, say, 80% of the population, 90% of the population, then it is assumed that your vaccination coverage to that level will provide the protection to the entire community of that particular area. So that is how it basically acts. But it is basically the preventive strategies which lead to the immunity, rather than exposing the person to the infection, and imagining that this particular exposure will provide immunity to the entire herd or the population.
Okay. So there are two ways in which herd immunity can be reached. One is a preventive strategy via, vaccination. The other is via exposure, something which the WHO Director General is referring to in terms of it being both scientifically and ethically not feasible there and problematic as well. Let me bring in Dr. Rajib Dasgupta here as well. Dr. Dasgupta, from your point of view, if you look at the concept of herd immunity and its Indian context as well.
Well, central to the concept of herd immunity, in addition to what Dr. Singh said, is that when do we actually know that we have achieved herd immunity in a context such as this? The answer to that is when the effective reproduction number, which is how many persons one infected person is transmitting to, falls below 1. Now, in the case, and this of course depends on a number of factors. So just to give an example, in the context of France, in the earlier phase of the pandemic, where this R0, the effective reproduction number, was 3, which means that one person spreads to 3 persons, there it would require, based on the computation, it would require 67% of the population to be immune for this to fall below 1. Now, currently, the global estimate is that anywhere between 10 to 15% people have been infected. Now, globally speaking, this is, or even for a country such as India's size and diversity, it will certainly take a few years at least at this rate for it to reach that level of safety. Now, the reason we are discussing or why this has become, if I may, a matter of debate at this point is one, what's called the Great Barrington Declaration by a set of scientists issued a few days ago, which advocates a certain line and therefore something which is akin to promoting the concept of herd immunity as a tool of control, followed by support from a certain political line in the US, which, as we know, is deeply divided between greater controls and lesser controls, and subsequently something called the John Snow Memorandum by another group of scientists. And that really has sparked up this debate. So what the WHO Director General said comes in a certain context. It's not out of the blue. And these are the events of the last 1 week. And at this point, we can discuss this later in detail. There are scientific implications, there are ethical implications, moral implications, and certainly political implications of this. And that really is the lay of the land at this point in the discourse in which we need to understand herd immunity.
Okay. We'll definitely come to the scientific and ethical, complication and implications out there of this particular concept. Let me first bring in Dr. Samiran Panda here as well. Dr. Panda, there was a sero survey conducted by ICMR, and when we talk about, how many people are right now infected in terms of, the surveys which have been conducted, what exactly is the scenario on the ground as of now? And if you extrapolate that data into the concept of herd immunity, does it make any sense to go that route in terms of using herd immunity as a preventive tool?
Well, that's a very good question. And the two issues that you have raised need to be juxtaposed to each other. So you did ask about sero survey. And the sero survey that was conducted 4 months ago, nationwide sero survey, that clearly showed that less than 1% of the general population in the country was exposed or got exposed to COVID-19, or more specifically SARS-CoV-2, the virus, and developed antibody against it. And that's what got captured during the sero survey. But the recently completed second round of sero survey has indicated that it has gone up by 10-folds. So it was 0.7%. So that's why I said less than 1%. But now it is 7%. Out of 100 people, general population, 7 had some evidence of getting exposed to SARS-CoV-2 virus, in response to which they developed antibodies, and that's what got captured while sero survey took place, and their blood was taken, or they were sampled. Now, this is a national average, but if you divide it in rural setting, it was 4%. If you go to the urban non-slum setting, it's 8%, and then in urban slum setting, it is 16%. So what does this basically mean? In an urban slum setting where the population density is high, meaning people sort of reside in close proximity to each other, there the chance of transmission naturally, because of the nature of the transmission of this particular virus that we are discussing about, is much more. So that's why it was not surprising to see that the sero survey detected presence of antibody among 16% of the urban slum-dwelling population, which was a little less, half almost, in the urban non-slum setting people, and then it was further less in the rural setting. Okay. Now, these many people did develop antibody. So naturally, people would think, oh, okay, so then they got exposed, they developed antibodies, so they are now immune, because immunity is the ability to to defend or to protect oneself against an infection. So as I got naturally infected, I will be able to defend it. But that might not be the case, because this is a new virus and this is a disease which we are yet trying to understand. So getting infected, or even through a vaccine, as Dr. Singh said, if we get the antibody developed within our body with the help of administration of vaccine, how long that protective ability or the immunity will remain is the question. We have evidence now that antibodies might not persist beyond 6 months to 1 year time. So herd immunity is about immunity in a group of people, and so if they come in contact with susceptible population, so the susceptible population is no way going to get the infection from them. That's the concept. That's the way people think. But if the herd immunity does not persist for long, there is a chance of reinfection. And then from them, susceptible population will be able to get the infection.
Okay.
So I think it would be too premature to say that, well, herd immunity is a mechanism that we could maneuver. Natural infection, during the natural infection, if many people get infected, it is not just the immunity that will take place and short-lasting immunity, as I highlighted, but there will be many casualties as well, because we know that when elderly people get infected, and if some of them have comorbidity, even if they are not elderly, there will be casualties, there will be death, there will be fatality. So we cannot let this herd immunity take its own course, saying that, well, let the infection spread and we will develop a herd immunity. That's a dangerous game to play.
Okay. Let's come back to those scientific and ethical questions which Dr. Dasgupta was mentioning about. Dr. Dasgupta, now that we have these numbers, the figures which have been pointed out by Dr. Samiran Panda from the ICMR Sero survey, one is what kind of scientific and ethical implications or complications which we are talking about if we deploy the concept of herd immunity, and how it is not feasible to deploy such a concept, specifically from the point of view of, as a preventive tool?
Well, the context, as I said, is now roughly after 6 months of varying restrictions, including some of the most severe restrictions across most countries in the world. And initially we thought, or at least the dominant idea was that with severe restrictions, the transmission would be cut down and near normal activities could be resumed in a visible time frame. That, unfortunately, as we know, hasn't been quite up to the expectations. And many countries continue to face restrictions, including some of our restrictions. So essentially what's happened is it's led to widespread, as one author commented, widespread demoralization and diminishing trust. And it is at this juncture that these two declarations, or these two schools of thought, are seemingly clashing. And this generates from the frustration that are lockdowns actually doing more harm than good? Now, lockdown is one extreme position, but there are certainly going to be a varying set of restrictions, which are certainly going to be there for some time. And therefore, one school of thought is, without taking sides, one school of thought is that a greater understanding of vulnerabilities is crucial, not just biological vulnerabilities of age or comorbidity, but into social vulnerabilities such as Dr. Panda said, the issue of urban slums, certain gender-related issues, people living and working in conditions where staying away from work or physical distancing or even hygiene, etc., is simply not possible.
Okay.
And therefore, the one argument is that we need more investment into communities and just not blank lockdowns. Now, as I was saying earlier, there are intensely contested political positions on this. There are contested scientific positions on this. Herd immunity per se, as the other panelists explained, is a question of removing some of these restrictions and let the infection run through.
Okay.
Now, as one of the leading ethicists point out, that it simply means that it's at one level it's okay if your grandparent passes away at the cost of at the benefit of saving younger lives, but that's also not going to happen, because even a grandparent's passing away does entail a cost on your family, and it certainly entails a cost on the health system.
Mm-hmm.
So these are not really easy choices, and certainly not easy comparisons.
Mm-hmm. Okay. Okay. Dr. S.K. Singh, I'd like to bring you in here on these two aspects, as Dr. Rajib Dasgupta pointed out, with examples as well, in terms of both the scientific and ethical implications and complications of deploying herd immunity as a preventive tool. Obviously, when we have the vaccine and the vaccination is used to, reach to a particular herd immunity level, that's a different aspect. But right now, in the situation we are in, is it not a concept which is not feasible?
No, I don't think that, because we are talking this because we don't have a vaccine. And in the near future also, we are not going to have vaccine for protection.
Mm-hmm.
So now whatever we have left with is the persons getting infected and persons getting immune due to infection or developing antibodies.
Okay.
But coming to the ethical part, ethically, because if we expose deliberately persons to infection leading to high mortality, high morbidity, that is ethically wrong. That's my one view. Second is regarding scientific evidence. As another panelist has rightly mentioned, that scientific evidence also right now does not give us conclusive confidence that how long these vector antibodies develop will provide us protection. That is one. Second is whether all the infected persons will have the desired level of antibodies in their blood, so that gives them the protection.
And what's the threshold there, Dr. Singh, if I may jump in? What's the threshold for the amount of antibodies in a particular person and the amount of percentage of infected people to achieve a herd immunity? Scientifically, what are those thresholds? Or these are, because there are varying figures which keep on coming in.
No, actually, truly speaking, no, there is no concrete evidence. Initially, we thought in New York that 20% has provided the protection. There was definitely a perceptible level of downward trend, which was observed not only in New York, but in our Kerala and many other places as well. Mm-hmm. Like in Europe, we are facing the second surge. Like France, Germany, I think you know that many other countries. And in UK, this particular strategy has failed altogether. So I don't think that deliberate expansion, our strategy in the absence of vaccine has been to gradually expose our population in a controlled manner so that our health system is able to deal with the diseased persons and also prevent the mortality. And in that regard, I must say that our government's efforts and the Ministry of Health's efforts and together with the people coming together have been successful to a great extent. And we are right now having one of the lowest mortalities in the world, that is 1.53. And also we are having very manageable, I must say, load on our health system. So okay. This is how we are dealing with this.
Okay, so you're saying that herd immunity is not an option, a feasible option as far as the Indian situation or the Indian context is concerned to tackle COVID-19, and neither it is being deployed as a strategy right now.
It is definitely not a public health strategy that you expose your population to the infected environment and hope that these people are going to get the antibodies for their own protection, because we really don't know. The scientifically evidence is not there, and ethically and morally also it is not correct that you expose your population hoping that out of these 100 people, 20 will get the severe infection and get into the complications and all, and also mortality, and then hoping that the remaining 80 will definitely get the immunity and be protected for the subsequent life. So I don't think that this type of approach is scientifically or from public health perspective is also a collect approach.
Okay. Dr. Samiran Panda, your concluding views on both these aspects, scientific as well as ethical and moral, in terms of utilizing or using this particular tool, that is herd immunity, as a preventive tool.
I think that herd immunity, if we go by hope and the expectations and theoretical compartmentalization, then it works very well on paper. Like, you allow the young adults or the younger population to get infected, and then you expect most of them to clear off the infection or come out of the acute phase of the infection, or even remain asymptomatic. And during that time, you protect the elderly or protect the most vulnerable. But can you really navigate it in a social setting? No. So theoretically, you can compartmentalize, you can draw certain compartmentalizations on a paper, but that's not going to be the case in the society, number one. Number two, here it is not only biology, but behavior, which goes hand in hand. So when the people, interact in a social setting or in a cultural setting, there are multiple factors which even influence the use of masks or use of distance or hand hygiene or the respiratory hygiene. So just talking about herd immunity, but not about the determinants of safer behaviors would not be an appropriate public health intervention approach. And the third very important piece of evidence that has been generated from UK, the healthcare workers who got infected they have in our country, in any country for that matter, due to the occupational exposure, many of them get infected. And the antibody concentration, you asked a question, what is the cutoff? What is the level? So the effective concentration, whatever that is dependent on the severity of the disease. So if somebody gets severe disease, they get very high concentration, and the effective concentration comes down to 50%. That's called EC50, effective concentration at the 50% level. That the healthcare workers who got infected had very high antibody level or even low antibody level because they did not have severe disease. All of them, over a period of time, they were followed for 90 days or more than 90 days. This is called antibody kinetics, that actually started coming down. So although the initial concentration of antibody was dependent on the severity of the infection, the antibody kinetics was not dependent. Okay. So it started falling down, and the concentration of the antibodies, the neutralizing antibodies, started coming down. So I would say that it won't be an ethical approach to consider that let the infection play and we would be protected somehow. It's like, a hope or an expectation, not necessarily based on a complete understanding and the balance between biology and behavior, which we cannot really navigate.
Okay.
We would probably desire to do so, but we are not able to navigate. So multiple factors need to be taken into account.
Okay, definitely. There are multiple factors, involved in this complex issue. Thank you so much, Dr. Samiran Panda, Dr. Rajib Dasgupta, and Dr. S.K. Singh as well, for sharing your views with us and our viewers on this important concept of herd immunity, which is being debated in public domain for quite some time now. And as our panelists pointed out, it is neither scientifically nor ethically feasible to use herd immunity as a preventive tool against COVID-19 pandemic based on various factors and various reasons as explained during the discussion. So let's remind you of one very important preventive tool here, and that is the behavioral change. 3 things which all of us can do in terms of ensuring that we do not spread COVID-19 or get infected to COVID-19 is wearing a face mask, washing your hands regularly, and also ensuring physical distancing of at least 6 feet. These are 3 simple steps which all of us need to follow, ensure that we practice them regularly. We'll come back again tomorrow with a different topic. Till then, keep watching Rajya Sabha television, and please do not forget to follow all these 3 steps. Thank you.